Hello everyone. Today we are going to talk about management of dengue, which is based on national guidelines for clinical management of dengue fever 2003, adapted from that. So the dengue management wise is very important to know because many of time in your clinical practice we see frequently this dengue patients and whose management becomes very important now. So these are actually divided into three groups, that is group A, B, and C. So group A are patients who have no warning signs, that is stable patients with dengue positivity. Group B is the patient who has warning signs, and this is called as moderate dengue. Group A are called mild dengue and group B is called moderate dengue. Warning signs like persistent vomitings, abdomen pain, rapidly rising hematocrit, any bleeding from any site like epistaxis or melena, hepatomegaly of more than 2 centimeter, hepatomegaly of more than 2 centimeter. So all these things comes under the warning signs. Suppose these warning signs are there, the patients need to be admitted and managed. Next, dengue group C is nothing but the dengue hemorrhagic fever, hemorrhagic shock. This is the very severe form of dengue that's called as severe dengue and dengue hemorrhagic shock. So coming to the management part, suppose a patient has only group A, that is mild dengue, will usually managed on OPD basis with oral fluids. You should give oral fluids has to be given to this patient and will be managed based on that. You need to avoid any nephrotoxic drugs because these patients are already prone to pre-renal AKI because they are dehydrated. Because of dehydration, there could be acute kidney injury. So to avoid that, you need to avoid NSAIDs and aspirin in this patient. So suppose patient has a moderate disease, that is patient have warning signs and has presented to you, then the main goal of treatment or mainstay of treatment is IV fluids. So the usual dose is calculated is based on 7 to 10 ml per kg. That has to be given over 1 hour as a bolus. This is the initial bolus which you give. And after giving this much of fluid, if the patient, you check for patient response, that means you'll check for the urine output. You look for the other perfusion parameters like skin turgidity, how the patient consciousness is there or not. And if you want to monitor, you will do a PCV. Suppose all these things are favorable, that is urine output is coming good. Normally it has to be at least 1 ml per kg is normally which occurs per hour actually, but minimum at least 0.5 ml per kg per hour urine should come. So if this is coming, PCV is decreasing, that is hematocrit is decreasing, perfusion is being maintained, symptoms are getting better, then means that patient has tolerated that, and now you can decrease the fluids to 5 to 7 ml per kg per hour. So this fluids you will give again for 2 to 3 hours. Again, you will reassess if all the parameters are in favorable. Then you decrease it to 3 to 5 ml per kg per hour. Then again, you give it for 2 to 3 hours. Then again, you will check that if the patient is favorable, then you give 2 to 3 ml per kg. And this has to be continued for 24 hours. So once after 24 hours, suppose the hematocrit is decreasing, vomitings has decreased, patient is able to take oral intake is good, BP is good, and everything is in favor. Urine output is good, everything is favorable. You can stop IV fluids and you can keep the patient on oral therapy, oral fluids. So supposing patient has came with type 3, that is dengue hemorrhagic shock. So this shock can be either of two things. One is the acute capillary leak. Suppose there is too much of capillary leak. What happens basically in dengue or any viral fever is the capillary starts leaking, oozing out the fluid. And because of that, patient in the vessel, there is no volume left, and the patient will go into the capillary leak and called as dengue shock. So suppose patient goes into this type of dengue shock, what will happen is because the fluid is leaking out, all the blood cells are inside only, it becomes more and more concentrated and hematocrit keeps rising. So another thing which can occur is the hemorrhagic shock, where patient can actually starts bleeding due to decreased platelets or anything. Patient may can get active bleeding is there. Suppose bleeding occurs in the vessels, what will happen in bleeding? Both fluids and the blood will be lost. The cells will get more loss when compared to fluids, and hematocrit will be decreasing. So many of time, often we feel that hematocrit is decreasing. That means PCV is decreasing. We feel that patient is improving, but you should also see clinically. That means that suppose a patient hematocrit is increasing after IV fluids. If you're given IV fluids and hematocrit is decreasing, and along with that patient is conscious, BP is good, BP is good, output, urine output is good. So if all these are unfavorable, that means that patient is having good prognosis. But sometimes what happens is that even after giving IV fluids, you will persistently see that hematocrit is decreasing. So decrease hematocrit will there, but patient will be very much symptomatic. That means there is no improvement in that. So despite patient BP, so what happens is BP will be falling down. Patient will get more and more drowsy. Urine output is decreasing. So all these things are happening. So patient is getting worse, but hematocrit is still decreasing. So many often physician gets confused that why is this happening. So this time we should suspect that although hematocrit is a good prognostic, but if it is decreasing along with the persistence of decreased BP, increased drowsiness, decrease in urine output, we should suspect what is called as dengue hemorrhagic shock. So in this patient, you need to have give a packed cells, packed RBCs transfusion or whole blood transfusion is immediately required along with the platelets. So patients with dengue severe shock, the fluids which you should give is actually depending upon the compensated and decompensated. Suppose patient is compensated shock, that means BP is low, but patient looks conscious, urine output is okay, borderline maintained, then you can give 10 ml per kg per hour of fluids. Suppose patient is decompensated, that means urine output is decreasing, patient is getting drowsy. So all this perfusion defect is there, then you can give up to 20 ml per kg per hour initial fluid, and based on response, you can taper as we discussed for the moderate thing, like from 20 ml per kg per hour. If PCV is improving, patient is clinically better, then you come up to 10 ml per kg per hour for another 2 hours. If improving, then to 5 to 7 ml, then to 3 to 5 ml, and then to 2 to 3 ml. So this you can continue. So coming to the main topic again, so patient have mild dengue, that is group A, will be managed on OPD basis, adequate oral fluids. You can give paracetamol for fever around 10 milligrams per kg per dose. Avoid NSAIDs and aspirin. Watch for warning signs and daily monitoring of complete blood count if needed. Moderate dengue, which is persistent, have a warning sign symptoms like persistent vomiting, abdominal pain, mucosal bleed, clinical fluid accumulation of ascites, pleural effusion, liver enlargement of more than 2 centimeters, rapid hematocrit rise with platelet drops. This patient you should manage, admit to hospital, baseline hematocrit you should do to before giving IV fluids to see the response, and you will start giving fluids as discussed. That initially first 1 hour, 7 to 10 ml per kg per hour, then reassess if improved 5 to 7 ml per kg for 2 to 4 hours. If improved 3 to 5 ml per kg per hour for 2 to 4 hours. If improved, then 2 to 3 ml per kg. That you have to continue for 24 to 48 hours. So severe dengue, as we discussed, fluid management in this uh, severe dengue cases, what how we do is, so you look for compensated shock. That means patient have a pulse pressure of more than 20 millimeters of mercury with weak pulses. You give twisted bolus of 10 to 20 ml per kg per hour over 1 hour. And decompensated shock means systolic BP is less than 90. If patient is like that, then you should give a rapid bolus. Repeat up to 3 boluses if no improvement. So all these things can be done. Like more aggressive fluid therapy is given for patients with decompensated shock. So when to stop IV fluids after stopping, you will suppose the patient vitals is stable. Patient is afebrile for more than 24 to 48 hours. Hematocrit is normalizing. Good oral intake. Good urine output, no fluid accumulation or respiratory distress. So this is the time you will stop IV fluids in patients with dengue. So coming to indications for platelet transfusion in dengue. Platelet transfusion in dengue should not be a routine measure. It should be given only if absolutely indicated. The most absolute indication is that suppose a patient has bleeding. So patient presenting with bleeding manifestations and platelets of less than 50,000 per millimeter cube, then it is an absolute indication to give platelet transfusion. So active bleeding could be either mucosal bleeds, skin bleeds, internal hemorrhage like GI bleed, intracranial hemorrhage, etc. Transfuse with platelets less than 50,000 with bleeding. And suppose there is severe bleeding, regardless of platelet count, you should give platelet transfusion like profuse GI bleeding, hematuria, post-procedure bleeding, intracranial hemorrhage. If such type of thing is there, you have to give, irrespective of platelet count, you have to give platelet transfusion. Prophylactic platelet transfusion is only for selective uses. It has to be only given if the platelet count is less than 10,000. So more than 10,000, usually it is not required. And that too, it often said that suppose platelet count is less than 10,000 also, only in high-risk patients who are more prone to bleeding, like elderly patients, patient who are having multiple comorbidities, patient is planning for any invasive procedure, then only you give transfusion. Otherwise, routinely platelet transfusion, even for less than 10,000, is not recommended as such. So for invasive procedures, for any other procedure, the platelet count should be at least maintained more than 50,000 for any procedure. And suppose neurological procedure patient is going to undergo, then it should be maintained up to 1 lakh. So not recommended routine prophylactic platelet transfusion in stable patients without bleeding. Even if patients with less than 20,000, it is not recommended. Study have shown no benefit and there are risks include with what are the risks? There can be fluid overload. There could be alloimmunization. That means the transfusion reaction because of the platelets. Worsening of the capillary leak. Capillary leak can get more worsen because of this. So this is a problem. You should not routinely give platelet transfusion because patient can have worsen outcomes with this. So key points summary is that platelet transfusion should never be based on count alone. Always assess clinical signs of bleeding. Fresh blood or packed cells plus platelets may be needed if bleeding is significant. Dengue-related thrombocytopenia is often self-limiting and does not always require corrections unless bleeding is evident. Role of doxycycline, statins, and steroids in dengue. So current role, many of times we see in many of the prescriptions that patients or clinicians are prescribing doxycycline, but the national guidelines of dengue suggest that there is no role of doxycycline and this is no established role and it is not recommended for routine use in dengue by WHO or Indian guidelines. So however, why it was thought to be used was basically because of its anti-inflammatory action. So because dengue is an inflammatory state, anti-inflammatory action could be useful. That's what it was thought. So it inhibits dengue virus replication by interfering with NS2B, NS3 protease and matrix metalloproteinase inhibition. Conclusion, it is not routinely recommended for dengue unless there is co-infection with other diseases. Statins is also having anti-inflammatory action and often it was thought that it could be useful. Basically, mechanisms is it is immunomodulatory and endothelial protective effects, reduces cytokine production, and improves the endothelial function. So, guidelines currently recommended this have not included in 2023 Indian or WHO dengue management guidelines. It has promising but experimental, not standard therapy yet. Corticosteroids, it may suppress the cytokine storm, could benefit patients with severe capillary leakage. Suppose there is usually too much of leakage, basically is because capillary leakage basically occurs because of the inflammation. So this was thought that suppose patient has severe capillary leakage or shock, sometimes the steroids can be useful, but routinely it should not be given to all patients. Use only for specific complications, not in general dengue shock or plasma leakage. So current recommendation, doxycycline not recommended. Statins is investigation only. Steroids not recommended routinely, only for selective indications like severe dengue capillary leak, which is not responding to the IV fluids therapy or to the blood transfusions as well. If it is not responding to that, then it is the treatment of choice. Now, important thing, one more thing often we see in clinical practice, which is important to bring to your notice that many of times we see that patient is having dengue and and you have started treatment with IV fluids. Now, after starting IV fluids, patient is receiving therapy for almost 2 to 3 days. Now, you do X-ray, and you see that there is chest X-ray shows pleural effusion, mild to moderate pleural effusion. So often we jump into conclusion that this pleural effusion could be because of increase in IV fluids, and we try to stop the IV fluids. So this is a miss thing. That means that this should be never done. Why this pleural effusion is accumulating is basically because supposing this is a capillary artery, there is what happening is there is capillary leakage is happening. So this capillary vessel leakage is actually causing that fluid to appear as pleural effusion or ascites. That means that the volume is not staying inside the vessel. So that means patient has more tendency to go into shock because there is no vascular volume. In this patient, if you stop the fluids, what will happen is that the perfusion, the some amount of fluid which is going through the vessels, the perfusion will decrease more and more, and patient will land into acute kidney injury, may land into ischemia and all because of the decreased perfusion. So ideally, what we should do is suppose patient, whenever you see a patient having a pleural developing pleural effusion or ascites, you should actually increase the fluid, IV fluids, to prevent patient from the perfusion related shock. So actually, the shock to prevent the shock, you should increase the IV fluids when patient have pleural effusion or ascites because that is occurring because of the capillary leak and not because of your increased IV fluids. Thank you.